Welcome to the Deep Dive. Today we're tackling something a bit mysterious in the veterinary world, infections that really prefer the dark. We're talking about anaerobic bacteria. These are microorganisms that don't just tolerate no oxygen. They need that lack of oxygen to really cause problems. Our mission today is to give you a really solid but, easy to grasp understanding of these guys. We'll look at what makes them tick, how they get started, what signs to look for, and crucially, how we diagnose and treat them. The goal is real, practical knowledge.
Absolutely. And it's so important because, well, these microbes are everywhere. I mean, literally everywhere. Soil, water, even living quite happily inside animals. Think oral cavity, GI tract, skin. They're part of the normal flora.
Ah, okay. So they're normally harmless.
Often, yes, that's the paradox. They're just sitting there, but then under the right conditions, bam, they can become really serious pathogens.
Okay, let's dig into that. What exactly are anaerobic bacteria? You mentioned they don't like oxygen.
Right. Simply put, they're bacteria that can only grow and multiply when there's no oxygen around. It's fundamental to them. And it's worth distinguishing. You have your strict anaerobes, which oxygen actually kills or stops from growing. They're our main focus today.
Oh.
Then you have facultative anaerobes. They're more flexible. They can grow with or without oxygen. But the really dangerous ones, the ones causing these specific types of nasty infections, are usually those strict anaerobes.
Got it. So we're zeroing in on the real oxygen haters. Is there like a usual suspects list? Which ones do vets run into most often?
Oh, definitely. It's a diverse group, but we can sort of categorize them. You've got gram-positive cocci, things like Peptostreptococcus, often part of a mixed infection, and the gram-positive rods. This includes some real villains, the spore-forming Clostridium species.
Oh, like tetanus and botulism.
Exactly those. And others that cause severe muscle infections, Clostridial myositis, because they produce really potent toxins. There are also non-spore formers in this group, like actinomyces. And then there are the gram-negative rods, a really significant group. Includes Bacteroides, especially the B. fragilis group you see in abdominal infections, and Fusobacterium. F. necroforum, for instance, is famous for causing foot rot in sheep and cattle.
Wow, okay. Quite the cast of characters. You mentioned mixed infections. I've heard anaerobes often don't work alone. How does that work? Do other bacteria actually help them?
That's a fascinating point. And yes, it's almost always what we call a polymicrobial infection. You rarely find just one type. It's usually a mix of different anaerobes, often alongside facultative anaerobes or even strict aerobes.
So how do the oxygen-loving ones help the oxygen-hating ones? Seems counterintuitive.
It does, but think of it like this. The aerobes, or facultative guys, go in first, and they use up all the available oxygen in the tissue. They basically create the perfect anaerobic, oxygen-free environment.
Ah, so they set the stage.
Precisely. They consume the oxygen, paving the way for the strict anaerobes to then thrive and multiply and do their damage. It's like a weird bacterial teamwork.
It's quite something.
Yeah.
Okay, so once they're established in their little oxygen-free zone,
Yeah.
what makes them so destructive? What are their weapons?
They're virulence factors, basically. They're superpowers, if you like. Many, especially Clostridium, pump out powerful exotoxins. These can have effects far beyond the local infection site. Plus, they release enzymes that just chew through tissue. Things like collagenase, breaking down collagen, the structural framework, and hyaluronidase, which breaks down the sort of glue holding cells together.
Yikes.
Yeah, it leads to widespread tissue damage, necrosis tissue death, and can cause severe systemic illness. That's why these infections can seem to explode so quickly.
Okay, so they're opportunistic, waiting for the right conditions. What are those conditions? What makes an animal vulnerable?
Right, they need that low oxygen environment. So the predisposing factors mostly revolve around creating that. First category is anything that reduces oxygen supply to tissues. Trauma is a big one, crush injuries, deep puncture wounds, even surgery sometimes.
Makes sense.
Foreign bodies, like a splinter or something, can create a little anaerobic pocket. Tissue necrosis itself, poor blood supply from swelling or shock, that all reduces oxygen. And as we mentioned, having an aerobic infection already there can actually help the anaerobes by using up oxygen. Closed spaces like abscesses or the abdominal cavity and peritonitis are naturally low oxygen too.
Okay, so reduced oxygen. What else?
The other big factor is compromised defenses. If the animal's immune system is suppressed for any reason, they're more susceptible.
Right. So if a vet sees a case, what are the classic red flags? What screens anaerobe?
There are definitely some telltale signs, and understanding why they happen is key. The most classic, almost unforgettable sign is a really foul-smelling discharge.
The smell.
Yes. that putrid, pungent, sometimes even fecal odor. It's caused by volatile fatty acids, which are byproducts of their metabolism.
Right.
You often smell it before you even see it properly. It's that distinctive.
Okay, what else?
Gas production is another big one. You might feel crepitus, that crackling sensation under the skin, like Rice Krispies.
Rice Krispies, okay.
Yeah, it indicates gas-producing bacteria are present, often Clostridium. Then there's the appearance of the tissue. You'll often see necrotic, dead tissue. It might look dark, discolored, basically gangrene. Abscess formation is common too. Those walled-off pockets of pus are perfect anaerobic incubator.
Right, low oxygen inside.
Exactly. And if an infection progresses really rapidly, causing severe systemic signs like high fever, toxemia, shock, especially with muscle infections, you have to suspect anaerobes. Another huge clue is if the infection just isn't responding to standard antibiotics that only target aerobic bacteria.
That makes sense.
Also, the location matters. Infections near mucosal surfaces, mouth, gut, genital tract often involve anaerobes from the normal flora there. And sometimes you might even see black pus or exudate.
Black? Why black?
It can be due to breakdown products of blood, like heme derivatives, or sometimes bacterial pigments produced by specific types, like Prevotella.
Okay, so foul smell, gas, dead tissue, maybe black pus, and not responding to regular antibiotics.
Yeah.
Sounds like these infections can show up almost anywhere.
They really can. It's a huge range. You see localized things like abscesses, liver, lung, brain, under the skin. Deep wound infections are classic sites, bites, punctures, surgical sites where tissue might have died off. Oral infections are incredibly common, severe gum disease, tooth root abscesses. They can get into joints causing septic arthritis or bone causing osteomyelitis. And as I mentioned, foot rot in livestock is a major anaerobic disease.
And what about more serious body-wide infections?
Oh yes. They're implicated in severe pneumonias, especially pleuropneumonia involving the chest cavity lining. Peritonitis, a really dangerous abdominal infection. Pyometra, that's a severe uterine infection in unspayed females. Even pericarditis around the heart. And things like necrotizing fasciitis, the so-called flesh-eating disease, or severe cellulitis.
And then there are those specific Clostridium diseases you mentioned earlier.
Right, the toxigenic ones. Tetanus, with its characteristic spastic paralysis. Botulism, causing the opposite flaccid paralysis. Then Clostridial myositis, or malignant edema. These cause devastating muscle necrosis and can kill very quickly. And Clostridial enteritis, or enterotoxemia, which causes severe, often bloody diarrhea, frequently linked to C. perfringens or C. difficile.
That is quite a spectrum of serious problems. So, given how tricky they are, how do we actually confirm it's an anaerobic infection? Clinical signs give clues, but how do you nail the diagnosis?
That's a critical question. Suspicion is a start, but you really need lab confirmation, and the absolute key is getting a good sample.
Why is sampling so crucial here?
Because these bacteria hate oxygen. If you collect a swab and wave it around in the air, you'll kill the very bugs you're trying to find. So you need meticulous technique. Minimize oxygen exposure, use special anaerobic transport media, or collect pus in a syringe and immediately expel all the air and cap it.
Okay.
And sample from the deepest part of the lesion, not just the surface where you'll get contaminants. Aspirate pus from an abscess, get a tissue biopsy from the edge of the necrotic area.
And then send it to the lab. What's the gold standard test?
The gold standard is still anaerobic culture. The lab has to grow the sample under strict oxygen-free conditions. It takes time, though usually 48 to 72 hours, sometimes longer.
But it tells you exactly what's there.
Yes, and crucially, it allows for antibiotic sensitivity testing, so you know which drugs will actually work.
Are there quicker ways to get close?
Definitely. Looking at a sample under the microscope cytology using a gram stain can give you rapid information. You often see a mix of different bacterial shapes and sizes, which is suggestive. Molecular tests like PCR are getting more common. They can quickly detect specific targets, like the toxins from Clostridium difficile, for example.
What about imaging? X-rays or ultrasound?
Very useful. They can show gas in the tissues, which we talked about, or fluid pockets or abscesses that you might not be able to feel from the outside. And of course, you always have to consider other possibilities. Aerobic bacteria, fungi, even cancer can sometimes mimic these infections. So ruling those out is part of the process.
Okay, so let's say you've got the diagnosis. What's the battle plan? How do you treat these tough infections?
Right, and it's often an aggressive, multi-pronged attack. It's definitely not just about picking an antibiotic. In fact, the single most important part of treatment for many anaerobic infections isn't drugs at all. It's surgery.
Surgery. More important than antibiotics.
For many of these, yes. Specifically, surgical debridement, cutting away all the dead necrotic tissue, and drainage lancing and flushing out abscesses.
Why is that so critical?
Two main reasons. First, you physically remove the bulk of the bacteria and the dead tissue they're living in. Second, and this is key for anaerobes, you open the area up to oxygen. Oxygen is toxic to them.
Letting the air in again.
Exactly. It directly inhibits their growth, thoroughly flushing the wound, what we call lavage, and removing any foreign bodies are also essential parts of this mechanical cleaning.
Okay, so clean it up, open it up, then antibiotics.
Then antibiotics, yes. And while you're waiting for culture results, you'll often start with an empirical choice, something broad spectrum that you know covers common anaerobes.
What are the go-to drugs? The heavy hitters.
Metronidazole is a real workhorse. It's excellent against most strict anaerobes, especially those gram-negative rods like Bacteroides. Penicillins are still very important, especially for Clostridium and many other gram-positives, and some gram-negatives like Fusobacterium, often the top choice for clostridial infections. Clindamycin is another good one, covers gram-positives and some gram-negatives well. Big caution in horses, though it can cause fatal colitis.
Good to know. Any others?
Chloramphenicol has good penetration but has restrictions, especially in food animals because of human health concerns. Cefoxitin, a second-generation cephalosporin, has good anaerobic activity. And then the carbapamims, imipenem, meropenem, they're very broad spectrum, usually saved for the really severe or resistant cases.
Do you often use combinations?
Very often, yes, especially since these are usually polymicrobial infections, and you need to treat for a long time, weeks, sometimes months, much longer than for typical aerobic infections.
And are there antibiotics to specifically avoid?
Absolutely. Aminoglycosides, drugs like gentamicin or amikacin, they need oxygen to get into the bacterial cell, so they just don't work against strict anaerobes. And most fluoroquinolones, like enrofloxacin, generally have poor or unreliable activity against anaerobes.
So surgery, drainage, targeted long-term antibiotics. What about general support for the animal?
Crucial. Fluid therapy is often needed to combat dehydration and shock. Nutritional support is vital, especially if they're sick for a long time. Pain relief and anti-inflammatories, definitely. For specific diseases like tetanus or botulism, giving a specific antitoxin can be life-saving. And good general nursing care, keeping wounds clean, maybe using hot compresses to improve circulation, careful bandaging, it all contributes.
Is there anything more specialized? I think I've heard of oxygen therapy.
Yes, hyperbaric oxygen therapy, or HBOT. Putting the animal in a chamber with high pressure, high concentration oxygen, it can be really beneficial for severe anaerobic infections.
How does that work?
It delivers high levels of oxygen directly to the tissues, which, as we know, directly harms the anaerobes. It also helps the animal's own immune cells work better. It's usually an adjunctive therapy, used alongside surgery and antibiotics in tough cases.
Okay, quite an arsenal. So, putting it all together, what's the typical outcome? What's the prognosis?
It really varies hugely depending on the location, the severity, the specific bacteria involved, and how quickly treatment is started. Generally, the prognosis is good for straightforward, localized things like a subcutaneous abscess that's easily drained and treated early.
Right.
It becomes more guarded for deeper infections, bone infections, widespread cellulitis, or infections in tricky spots like the chest cavity or brain.
And when is it really bad news?
Unfortunately, the prognosis is often poor to grave for those severe, rapidly progressing clostridial infections like malignant edema or cases with overwhelming sepsis or severe tetanus or botulism. Timing is everything with those. But across the board, the keys to a better outcome are always the same. Recognize it early, be aggressive with that surgical debridement and drainage, and use the right antibiotics for long enough.
Early and aggressive intervention seems key. So finally, what about prevention? Can we do anything to stop these infections from starting?
A lot of it comes down to good basic animal husbandry and veterinary care. Prompt and proper cleaning and treatment of any wound is paramount. Don't let minor wounds turn into major anaerobic infections. And one specific thing to be aware of is intramuscular injections. While necessary sometimes, certain irritating drugs given IM have been linked to causing severe clostridial myonecrosis at the injection site.
Really? Just from an injection?
It's uncommon, but it happens. So, careful technique is important, and if an IM injection is given, especially with potentially irritating substances, it's really wise to monitor that site closely afterwards for any unusual swelling, pain, or heat.
Good tip. Okay, so as we wrap up this deep dive, it really strikes me that these hidden oxygen-hating bacteria, they demand this unique approach.
Hmm.
And often the most powerful tool isn't the latest drug, but something fundamental like drainage.
Exactly. Letting the air in, removing the dead tissue, it leverages their own primary weakness against them. It's basic biology turned into effective treatment.
It really underscores the importance of understanding the fundamentals.
It absolutely does. And perhaps the final thought to leave you with is this. Understanding the specific environmental needs of a pathogen in this case, the anaerobe's need for no oxygen isn't just academic. It's the practical key to controlling it. It makes you wonder, doesn't it? How might that principle, understanding the unique environmental requirements of a problem, apply to tackling other complex challenges, maybe even ones completely outside of medicine?